Hello, everyone, and welcome to Care Talk. My name is Laura Packard, and I'm your host. I'm also a cancer survivor who has firsthand experience of the American healthcare system. So please text or call in your health insurance and healthcare questions at 202 838 6837, and we'll get you answers in future episodes. And be sure to subscribe to my channel or podcast wherever you get your podcasts for more Care Talk. Today, we have special guest Margarida from Healthcare for America Now to talk about what's going on with healthcare under the Trump administration, which is so many different things. So, welcome, Margarida.
Thank you. Thanks for having me, Laura.
So let's start by talking about some of the policies that we may be seeing sooner rather than later. What are you hearing could be happening?
The thing that we're hearing the most about, so there's a couple of ways that President Trump, the Trump administration, and the Republican Congress, because of course he's taking office along with a majority Senate and a majority House. There's a couple of different ways that they could make changes. So the primary way that I'm going to focus on is legislative. It's what we think is going to happen in Congress. And we actually have a lot of information about that because the President Trump and the Republicans are not at all secretive about what their plans are for healthcare. And then I'll also talk a little bit about administrative actions. And administrative actions are things that the president can do unilaterally. And some of the administrative action is going to depend on who ultimately is confirmed in key roles in the administration. So, that RFK Jr. is up for the position of HHS secretary. That is a really important position. Health and Human Services, HHS, huge agency, controls lots of things, and not just health things, by the way. It also controls a lot of things around the food supply, and even touches on some climate things. So depending on whether or not he actually gets confirmed, we could see different kinds of changes. And then, of course, CMS, huge agency, that is the agency that runs Medicaid and Medicare, the two largest healthcare programs in the country. Dr. Oz is up for that spot. If he gets confirmed, a certain set of things could ensue versus maybe some other things. So let me talk a little bit about what we know, because we've been seeing it in the news for a couple of months now. And that is in Congress, there's going to be a plan. There's going to be a big bill. It's a reconciliation bill. No one needs to know that word. But basically, that is a huge package that's going to pass through an expedited process in Congress. And the centerpiece of that bill is going to be a renewal of the Trump tax cuts. And you might be asking yourself, what the hell does that have to do with healthcare? A lot, as it turns out. The president wants to renew his tax law, which expires this year. And that is going to cost a ton of money. It's about $4 trillion. Most experts say between $4 and $5 trillion. And he wants to pay for it by making very large cuts to Medicaid. Medicaid is the state and federal funded program that pays for many, many services for people of all ages. So, for instance, half of all kids are insured under Medicaid. Long-term care for seniors. If you've got a relative, a senior, or a person with a disability in your family that gets in-home care, either in the community, or they get full-time care in a long-term care facility, that's usually Medicaid paying for that. It pays for births. In most states, Medicaid pays for half of all births. It also pays for birth control in a lot of states. It also pays for substance abuse treatment. It also pays for mental health treatment. So Medicaid, huge program, touches about 80 million people and is a really key source of funding. The GOP right now is saying they want to cut between $2.3 and $2.7 trillion out of the program. That's really unprecedented. We have seen often in the past lots of efforts to tweak Medicaid, cut it, do various things to it, but I've never seen anything at that scale, and that would take a huge bite out of healthcare for millions and millions of people. And then for people who don't have Medicaid, but they have private coverage, including coverage under the Affordable Care Act, as I have, the Republicans have already said, and they were saying this, frankly, even before President Trump got elected, that they do not intend to extend tax credits that are tax credits provided to people buying insurance on the exchange. A lot of people, like 90% of people who get insurance on the exchange, get tax credits to make the coverage more affordable. These are enhanced tax credits that got more generous in the Biden administration in order to give people access to affordable health care. And they're going to expire at the end of this year. And the Republicans are already saying, we're not going to renew those because actually we need to spend that money to pay for that tax cut bill. So I think that is going to be the centerpiece of what we're going to see legislatively, at least in this first year. But keep in mind, a lot of the folks on the Republican side really have a theory that the United States, is spending too much on healthcare, and they want to see reductions. And so they may not stop at Medicaid and the Affordable Care Act. They may also try to cut Medicare. They may try to make changes to Social Security disability insurance. Really, everything's on the table, and there's this added pressure because there's now going to be a new agency in government, this DOGE, D-O-G-E. That is an agency that is really about, they say it's about government efficiency, but really what that's going to translate into is a lot of cuts to programs. So I think on the legislative front, we're going to see, frankly, a little bit of a repeat of what we saw last time Trump was president, but much more accelerated and much more extreme. Administratively, I think we will see a lot of changes that are going to be really what we'll see in a lot of the agencies, which is a potential rollback of some of the things that President Biden passed. So I'll pause there and see if you have more specific questions.
I think that is a pretty good summary, but for people who are listening, you and I both have health insurance through the Affordable Care Act, and we remember in 2017 fighting the repeals and stopping the repeal by just one vote in the Senate, John McCain, who is no longer in the Senate. For these fights that are coming, for these cuts that are coming, do we have the ability to stop them? Are the votes going to be close enough in the House and in the Senate that we, the people, will be able to make a difference?
Well, I think that just depends on what people do. And I think actually what people do back home is way more important than anything that we do in Washington, D.C. One thing that's really critical about Medicaid, it's a massive source of funding to states, and many conservative states and big rural states that tend to have Republican legislators in Congress are actually more dependent on Medicaid than some of the bluer states. And so whether or not we will be able to stop it really just depends on what people out in America are going to do. And it really depends, frankly, on us alerting people that this is even happening, because there are a lot of people who are not really paying attention. And because we know going into an era like this, everything is hyper politicized. There's a lot of hyperbole. People can't necessarily discern what the hell is really going on, right? They're reading the news and it's very chaotic. And every day there's 14,000 stories about tariffs and lawsuits and this, that, and the other. So part of it is going to be whether people in district and people in states can actually alert, activists can actually alert their friends, their neighbors, their coworkers about what is going on with Medicaid, and our ability to actually contact members from the district. One thing about this election is it doesn't matter whether you voted for President Trump or not. When the Medicaid cuts come, they're going to affect everybody. There isn't anybody at the federal government level that's going to say, we're cutting Medicaid. Oh, but wait, this person voted for President Trump, so we won't cut their Medicaid. No, it's not going to work that way. They're going to restructure this program to orchestrate very large cuts, and people will suffer under these cuts, regardless of who they voted for. And the people that lawmakers need to hear from are people who are going to suffer that impact in districts. So it's really our responsibility, and we have lots of partners that are just, this is their full-time work. They're out in states talking to people and alerting people right now about how dangerous these cuts are and what the actual impact is going to be on seniors, on people with disabilities, on kids, on working adults that don't have access to private coverage. So I think we have a good chance because Medicaid is so popular. And we've even seen in many, many conservative states, Medicaid expand via ballot measure because it's incredibly popular. But the burden is going to be on us to make sure people know what the hell is going on and what they can do about it.
And so these cuts, this would come through Congress and legislators would vote on it. Even in an expedited process, there's going to have to be votes before these things happen. What
Yeah.
are the things you talked about that the administration could do that don't require a vote, that President Trump could just do by executive order?
Yeah, well, he did one already today. So there's lots of things he can do, for instance, on reproductive health. So on reproductive health, today he extended the global gag order, which is something Republicans frequently do. They prohibit money given to foreign countries from being used for abortion. So, but there's other things he could do. So, for instance, President Biden signed a whole series of executive actions to reduce waste in Medicare, to facilitate more staffing in nursing homes. This is for the first time ever, there's going to be actually a staffing standard in nursing homes across the country that was just implemented by the president, by the previous president, President Biden. So the Trump administration could just roll all that back. He could just say, you know what, actually, never mind, we're not going to do all that. He could do some of the things administratively that we saw him do last time. So, for instance, there is record, I know you know, Laura, there's record enrollment, again, under the ACA because people have access to these enhanced tax credits and tons and tons and tons of people are signing up, 24 million people signing up for the Affordable Care Act. But one of the reasons why we've been able to do that is because there's very robust enrollment. So the enrollment periods are longer and became longer under President Biden. He reinstated navigators to help people sign up because signing up for health insurance is complicated. So we saw last time around, one of the first things that President Trump did in his first term was he got rid of all that. Right? He reduced the enrollment period. He defunded all of the public education efforts and the help with sign up and the community navigators, all that stuff. Well, what we know is when you make it harder for people to sign up for coverage because they don't understand what the hell it is or where they get it or how they sign up, we see decreases in enrollment. I think we can bet on that happening again. The president is still very sour on the Affordable Care Act, and even during his campaign for president talked again about repealing it. Now, I haven't seen that he's gotten super support from Republicans and backing him up on that, but he clearly hasn't let go of the idea that he wants the Affordable Care Act repealed. So he will do a series of things to sabotage. He'll loosen up the rules and regs so that junk insurance plans can participate in the marketplaces, right? Junk insurance, not so good. They're catastrophic plans. They don't pay for prevention. They really degrade the quality of insurance overall. So we'll probably see some of that. So I think we're going to tend to see a bunch of things like that. And I think we may even see a tax on the last big healthcare reform that we saw pass, which is the prescription drug reform that passed in 2022. In 2022, advocates passed a bill that created $35 insulin for people in Medicare. Medicare is the federal insurance program for seniors and people with disabilities. Big program, 75 million people. And under Medicare, there had never been negotiated prices for prescription drugs, which is crazy, right? Medicare is the largest purchaser of prescription drugs. So the fact that we weren't negotiating on prices and essentially the drug companies could just charge whatever the hell they wanted is really insane. It was costing a fortune, both to enrollees and to taxpayers. And so the law passed, it created $35 insulin, it created a cost cap for seniors for the first time. So seniors aren't going to have to pay more than a certain amount every year. It created negotiations for lower prices for all kinds of drugs, really popular drugs. It was 10 in 2023. Now the list was just released, another 15 drugs like Ozempic, the weight loss drug, lots of asthma drugs, lots of blood pressure drugs are also on that list. So the president could decide that he's going to change the way we do negotiations, right? So like negotiations is just that, it's negotiations. We need an aggressive HHS CMS team to be bargaining on behalf of consumers with the prescription drug industry. Is that going to happen? I'm not clear. I don't know that much about how, RFK as a prospective HHS secretary is going to handle the relationship with drug companies. So we could see any or all of those things happen in addition to many, many other things. And we could also see things happen in other agencies that are not necessarily healthcare agencies that ultimately benefit health. So, that's just another thing to keep in mind, that if there's an attack on the FDA, which is the agency that approves drugs, that could then translate into people having harder access getting the drugs that they need to stay healthy. So all of these things are things to watch out for. We don't know. But, the thing that I think is important is that people participate when something comes up, because one thing that's true about rulemaking, especially if we're making there's a rulemaking to do something new or to make an adjustment in an agency, it's typically done through a process where the public has some ability to weigh in. So if people weigh in, it's a signal to the administration, it's a signal to decision makers that there are issues, there's discontent, that people are concerned.
Thank you, Margarida. And for everyone listening and watching at home, please follow Healthcare for America Now to stay up to date with these attacks on healthcare going forward and what you can do about it. And now we're going to answer some of your health insurance questions with Louise Norris from healthinsurance.org. First question for Louise. Open enrollment for the Affordable Care Act is over, but people can still sign up for health insurance if they have a qualifying life event. So what does that mean? Who can still get health insurance?
Yeah, that's a great question. So first of all, open enrollment did end in the majority of the country on January 15th, but it does continue till the end of January in a few states, including some big states like California and New York. And it goes actually all the way till the end of February in Rhode Island. So there are Virginia, Massachusetts, California, the District of Columbia, New Jersey, New York, and Rhode Island all have deadlines after January 15th. So if you're in one of those states, depending on when you're watching this, you could still sign up. And we do keep an updated page of deadlines on healthinsurance.org if you missed that list. If you are in a state where enrollment has already ended, which again is the case in the majority of the country, you can still enroll in health coverage if you experience a qualifying life event. That includes things like losing other coverage. That's by far and away the number one qualifying life event that allows people to sign up outside of open enrollment. So if you leave, it has to be involuntary loss of coverage. It can't just be because you stop paying your premiums. But if you leave your job, for example, and employer-sponsored coverage ends, you do have an opportunity then to sign up for coverage in the marketplace. If you have a baby, if you move to a new area where different health plans are available, you do have to have had coverage in your previous area, but it allows you to switch to a new plan in the new area when you move. So it's life events that basically make it to where you need an opportunity to get new health insurance. Those are baked into the rules to allow you to do so. There's also in almost every state, there's a special enrollment period for people who are eligible for subsidies in the marketplace and whose household income isn't more than 150% of the poverty level. So if you're on the lower end of the income spectrum and you think you might be eligible for this, you can enroll anytime. It's worth checking. You can go to healthcare.gov. They have a pre-screener tool that will help you figure out whether you're eligible based on your income. And that enrollment opportunity continues year round. Native Americans can enroll year round. So depending on your circumstances, you may still be able to sign up even though open enrollment has ended.
Thank you, Louise. And our next question is, what should people do if they're uninsured, but they're not eligible for the Affordable Care Act? Since open enrollment won't start until November, that's several months away.
It is. So if you are uninsured and you don't have a special enrollment period, first you can check to see if you might be eligible for Medicaid or if your kids might be eligible for Medicaid or CHIP. This is going to depend on your income. The income limits are different in different states. So you can, and Medicaid and CHIP enrollment continue year round. There's no open enrollment period for that. So you can check with your state Medicaid office to see if you might be eligible. If you work for an employer that provides health insurance, it's important to note that their open enrollment periods aren't the same as the Affordable Care Act open enrollment period. Employers set their own open enrollment periods. Oftentimes they do it in the fall because they have a plan year that just follows the calendar year, but they don't have to. So you might find that your employer's plan year runs from, April to the following March, in which case they would have their open enrollment in the early spring in time for that and starting that new plan year. So if you work for an employer that offers health insurance and you haven't signed up for it in the past, check with your employer to see when they run open enrollment, because it might be sooner than you think. And then if all else fails, check with charity care programs at your local hospital, federally qualified health centers. There are ways that you can get assistance. It's usually income dependent. And for sure, mark it on your calendar to sign up for health insurance during the next open enrollment period, which starts November 1st.
Thank you, Louise. And a next question, this came in via text. This person wants us to talk about self-funded ASO plans, where this is your employer is also your insurer. So can you tell us what ASO plans are and how this works?
Sure. So self-insured plans are basically where the employer is using their own money to cover their employees' medical costs. So they're not buying health insurance from an insurance company. They're instead just using their own money for this. In almost all cases, though, they contract with an insurance company to do the administration, to set up the network, to administer the claims, to make the payments to the providers. So people oftentimes don't realize that their coverage is self-insured by their employer because they just get an insurance card, an ID card that has an insurance company name on it. But the majority of people who have employer-sponsored health insurance are actually in a self-insured plan as opposed to a fully insured plan. Fully insured means the employer purchased a policy from an insurance company and the employer pays premiums to the insurance company and the insurance company pays claims. Whereas with self-insured plans, the employer just buys administrative services from the insurance company and it's the employer's money that's being used to pay claims. And self-insured plans are subject to federal rules, but not state rules. That is the big point that people need to understand about self-insured plans. If your state, for example, passes a law that says health insurance plans have to cover infertility services, for example, have to pay for IVF, that will not apply if your plan is self-insured. And again, remember, the majority of people with employer-sponsored coverage are in self-insured plans. So states regulate their own insurance markets, but that's for fully insured products. That's for individual health insurance that you buy like through the marketplace. It's for small group policies that small employers purchase from an insurance company, and it's for large group policies that insurers purchase from an insurance company. But if an employer decides to self-insure, they are only subject to federal rules, not state rules.
Okay. Thank you for that. And the next question, this person wants to know, how do we start our own co-op health insurance in our area? Is that something that somebody could do?
So a word of caution, I would say here. Basically, the Affordable Care Act did create a provision for co-ops. And back in the fall of 2013, when the ACA compliant health insurance plans were rolling out, there were 23 co-ops across the country. Almost all of them failed. There are only 3 that are still operational today. The vast majority of them failed because they just the funding, there were all sorts of administrative problems with how everything was worked out under the ACA for these plans, but basically they just did not have the funding to cover their enrollees' costs, is how it boiled down at the end of the day. And almost all of them had failed within the first 2 or 3 years. So starting a co-op pretty much would require state legislation or federal legislation and extensive oversight from the state insurance commissioner. There are programs, Washington and Colorado have public option programs, sort of quasi-public option programs that they have debuted over the last few years, where there's more intensive state rules on in terms of like premiums and benefits and how much they have to pay to providers. There are sort of more intensive state rules than apply to other health plans, but those did require legislation and a lot of insurance oversight from the state insurance commissioner. So I would say starting a health co-op without that, no, it is not possible. It's very tempting, I think, sometimes for people to try to go outside the current regulated insurance system and join something like a healthcare sharing ministry or a direct primary care membership. Don't do it. Those are not health insurance. They do not have the sort of guarantees that health insurance does. They are not regulated by the state insurance department. If you are in a healthcare sharing ministry and they don't pay your bills, you have no recourse. You can't go to your state insurance commissioner and file an appeal and have them step in. They just can't do anything. And direct primary care memberships are just what they sound like. They pay for direct primary care. When you go to a primary care facility, whatever procedures they can provide for you there will be covered by your membership. But any sort of more significant care that you might need that's not primary care is not covered. So in our current environment, you can't go without real major medical health insurance that's compliant with the Affordable Care Act, regulated by your state insurance commissioner. It's just too risky to go without.
And going back to what you said about Washington and Colorado, and Nevada is another state that has
coming on board in 2026, I believe, will start to debut.
And Minnesota also. So we're going to see more public options in the states. I think we're going to see more regulated versions of health insurance. Although we'll see how all that turns out. It has been small to start. Only a couple states have implemented them, but that's probably the closest equivalent to a co-op that there is right now. If somebody's interested,
is growing in those. Washington and Colorado, they're definitely seeing enrollment growing in those plans. They do seem to be succeeding with the regulatory environments that the 2 states have put in place. So other states can learn from, there's definitely a learning curve and a process that states go through with this. And if states are successful, other states can sort of take that model and use it as sort of a turnkey approach.
And do you want to speak a little bit about basic health plan, which is another direction that states like New York and Oregon now have taken?
So the basic health program, that's actually part of the ACA as well. The ACA allowed states to create this, but for the first decade, New York and Minnesota were the only ones that did it. Oregon joined them last summer. So we do now have 3 states that have this. And basically what it is, under the ACA, it's sort of bridge coverage. If you earn too much money to qualify for Medicaid, but the ACA said up to 200% of the federal poverty level. New York has since extended that up to 250%. They got a federal waiver to allow that. Minnesota and Oregon both have stuck with the 200% of federal poverty level. You basically get coverage that's closer in benefits to Medicaid than to marketplace plans. So you have no premiums, although that could change when the subsidy enhancements that Margarida was talking about, if those expire, we could go back to having at least small premiums there. For the time being, no premiums and very low out-of-pocket costs, much lower than people would have if they were on marketplace plans. So that option is there for any state that wants to pursue it. The state gets the funding that the federal government would have otherwise paid in premium subsidies for those folks to enroll in marketplace plans. That gets funneled back to the state to run this basic health program. So that is a possibility. Kentucky was considering it, but pulled the plug on it before getting anything set up. But we could see other states do this and just sort of give people a buffer between, because right now the switch from Medicaid to a marketplace plan can be pretty significant, especially if people don't realize that they should pick a silver plan. You know, if your income is a little above the Medicaid level and you pick a silver plan, you have very low out-of-pocket costs due to cost sharing reductions. But if you pick a bronze plan because you don't realize about the cost sharing reductions, you go from having very minimal out-of-pocket costs under Medicaid to like a $9,000 deductible on a bronze marketplace plan. So basic health programs help to smooth that transition, giving people an option for really good coverage when they're a little above the Medicaid level.
Well, thank you very much for that, Louise. And thank you for all of your answers. And for everyone watching or listening at home, text or call in your questions at 202-838-6837 for answers in future episodes. So be sure to join us next week for more. And be sure to subscribe to my channel or podcast wherever you get your podcasts. This is Care Talk.